eliminate over 34,000 days in the hospital, and save $80 million across the state. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take the pledge and learn more about HTC, please visit our website at healthytransitionscolorado.org. So I have a couple of things just before we get started. All the phone lines have been muted, and they will remain so throughout the webinar. We're going to be using the chat feature available, I believe it's in the lower left-hand corner of your screen, to field questions and allow you to make comments on the discussion. This presentation will also have a few questions that you'll be asked to answer, and you can use the chat field for that as well. Questions posed to the presenter will be answered during the question and answer session at the end of the webinar. This webinar is being recorded and will be posted to the Healthy Transitions site so that you can access this information again at any time without cost. So I'm now going to turn the program over to Dr. Tiffany Noel Brown. Dr. Brown is the Executive Director and founder of Own Your Own Health, a Colorado-based nonprofit aimed at encouraging, developing, and supporting ownership of your health and health care. Own Your Own Health works with community members to be informed, prepared, empowered, and engaged in their health care. Dr. Brown will be discussing various frameworks for patient and family engagement and outlining some tools that you can use in your organization. Dr. Brown?
Hello, everybody. So at this point, we're going to switch over so that I share my desktop with you, and hopefully we'll get this to work correctly. Okay. Did that work? Can you see my PowerPoint okay?
We can. You're not in slideshow, though.
Okay. I am in slideshow on my screen, so I'm not quite sure why that's not showing up. Is it big enough for you all to see it on the screen as it is, and we'll just move through it like that?
Good enough for me. Let's just go with that.
Okay. I want to give you a little bit about my background so that you all can understand the perspective that I come from when I come to this work in transitions of care, and really including patients and families and learning how to engage them. And today I know that we will have a lot more questions than answers, and that's kind of the point of trying to get us to really think and push and be a little bit uncomfortable in this discussion. But a little bit about my background. I have my PhD from the University of California, San Francisco in medical sociology with an emphasis in health policy. And then I went and became certified as a sociological practitioner in community health. So I consider myself an applied practitioner of sociology that utilizes sociological concepts to really improve the healthcare system and also how we engage with our own health. In addition to that, a little quirk in my background, I recently became a Reiki practitioner and have been trying to learn more about alternative perspectives on health so that I can better help patients and family members that I coach to be able to figure out what is the right path for them and what science can we use in really trying to stay healthy as well as engage with the healthcare system, and especially during transitions of care when people have lots of questions about all the different types of things that are out there to help them. How do we really make sense of that? And that's really the perspective that I come from. Job-wise, I have been on the Safe Transitions Task Force in Colorado Springs and on the Patient Engagement Committee, and we recently wrapped up our work there and have some products out of our work to help patients and family members understand different levels of care. If anybody's interested in any of those resources, I'm happy to get them to you. And then I was also part of the Medical Home Initiative Standards Task Force in 2007, and we'll go through that a little bit later. But really, we were, as a state, trying to figure out what is this concept of medical home and what's even important in that. And those concepts, even though they came out of primary care, really are important for transitions of care. And I used to be on the faculty at the medical school here in Colorado, really working on patient safety, quality improvement, and patient-centered medical home ideas. At the same time, I had some time with CCHAP as their Director of Continuous Quality Improvement. So you can kind of see a little bit of my background really coming from a biomedical focus and really trying to add in this patient and family voice. And I extended that work by starting Own Your Own Health in 2010 as a way to develop and encourage patient and family voice, not only during interactions within the healthcare system, but also having a voice as we change the system, being part of the system change. And I really want to step back for a second and really say, even though you and I are both here as professionals today, we're also patients ourselves and family member advocates with all of the information that we have. So these issues impact us both on a professional and a personal level. And in the past year, I have assisted with over 10 transitions of care in my own family alone, between my grandmother and my brother who was in a motorcycle accident. And even with all of my knowledge of the healthcare system and all of my efforts with Own Your Own Health to help people, I still couldn't protect them fully. But today I'm giving you the best strategies that I know of and that I use to pull from to engage my family members and engage myself, honestly, in their transitions of care. So today I really want us to think about the ideology that Own Your Own Health comes from. Be informed, be prepared, be engaged, and be empowered. And that equates in safe transitions to being safe. But before we start today, I really want us to think about how we're trying to explore how we can engage patients and family members better, especially during these transitions of care that we're all concerned about and at the table here for. This is a high-risk environment. And so really thinking about how to do this is really challenging. And I acknowledge that I don't have all the answers. And I also acknowledge that you're the experts in your organization and community. So if you have ideas, please bring them to the table. All we can use is the data and theories and our experience to springboard us into trying better ways of doing things. And if we can encourage and support patients in being informed, prepared, engaged, and empowered, we can assist in our efforts to have safe transitions. They're just another group that can be part of the solution here. There's another set of eyes and ears that are solely focused on their own case, and that's their ears, while we're focused on a lot of things going on at the same time. So they can be our best advocates. But let's step back. Yeah.
I'm sorry, Dr. Brown, this is Kristen. Just on a technical point, let's see if we can have you stop sharing your screen, move to slideshow, and then reshare your screen. The slides are a little tough to see the way we've got them working.
Sure.
We had it working before the webinar, so I'm hoping we can do it again.
Did that work?
No, it didn't. No, we're still back to seeing it the way it was.
Okay.
That's all right. You can continue. I was just wanting to see if there was some way we could make it easier to see some of these charts that you have.
Okay. If anything in particular is particularly hard to see, please, Kristen, again, stop in and just let me know and I'll explain what's on the screen. I can also try, does that make it a little bit bigger?
Yes, that helps slightly.
Okay. So that said, I'm going to go back one slide real quickly. I want this to be an interactive webinar, even though it's kind of awkward in the chat formation that we have to utilize. But I'm hoping that someone will feel comfortable playing devil's advocate today so that we can challenge each other and really start bringing out and promote the most thought-provoking environment for such a critical and kind of uncomfortable topic. Chime in using the comment section, and Kristen will read out for everyone to hear. And my philosophy, just starting this, is that everyone's voice is important, and you'll see that throughout my work. But for today, that means your voice is important and it's valued. So be engaged. And if you're feeling tentative and feeling like, I shouldn't really say that, or I don't want to disrupt anything, reflect upon that feeling that you're having and why patients and family members may also have that same reaction when they're dealing with the healthcare system and when they're dealing with you and may not seem as activated as we want them to be. So I'm just quickly going to go over the triple aim. I know you know this philosophy already, but I just want to bring it to the forefront of our mind. And I won't spend much time on it other than to just point out that one of the things in really looking at this triple aim is I'm thrilled that individuals and families have been included over time as this model has grown. But I also, if you see in red where I highlighted experience in care rather than experience of care, I want to make this a more active process where things aren't being done to patients or for patients, but they're being done with patients and family members. We're also all familiar with the chronic care model. So again, I won't go into that in detail, but again, I wanted to point out a model that over time has started to include informed, activated patients. You are the prepared, proactive practice team that's trying to activate those patients. So that's the role that we're going to be talking about today, and just bringing up that model that you're all familiar with. So one of the things that, and it did not switch. Are you all seeing, there we go. Are you all seeing a map now? Looks like the slides were lagging behind a little bit. Kristen, can you see a map saying at the national level?
PCMH model of care, is that what you're looking for?
Yes, perfect.
Yep.
So this is one of the things I'm going to ask Kristen to bring up a video on the patient-centered medical home model of care, and this is at the national level. But just in your comment box, if you could just type a Y for yes and an N for no, just really quickly, how many of you feel that you know this model well? Knowing it well, yes. Not knowing it, no. And we'll type that in as the video plays.
Tell you about a better approach to healthcare. So let's get started. Okay, everyone's health needs are different, but whether you see your doctor once a year or a lot more often, it can be a hassle. First, it's often hard to get an appointment. You rush to get there, but you may end up waiting if they're running late. And your doctor's rush too. So even though she'd like to spend more time with you, she only has a few minutes to find out what's wrong. The fact is, you may end up feeling like just a number or just the next person in a long line. So your doctor only hears about your sore throat or swollen knee, that pain in your back, or your daughter's cough, and there's no time for you and your doctor to really talk. It's even worse if you have a problem in the middle of the night and you're not sure if it's serious. Do you wait and try to get an appointment? Or do you go to the ER where the doctor doesn't know you and wants to run all kinds of tests? Will your insurance cover all those? It's a lot to deal with. And it's even more complicated if you need to see specialists like a cardiologist, an allergist, or a dietitian. That's a lot of different healthcare providers giving you tests, prescriptions, and treatments. And no one provider knows what the others are doing. When you think about it, they're each just looking at a piece of you, so no one sees the whole picture. Shouldn't this be a lot easier and less confusing? Well, yeah, that's why there's a new approach to healthcare that puts all the pieces together. It's called the patient-centered medical home, and it's a way to give you better, more personal care. Now, even though it's called medical home, it's not a place. It's actually much bigger than that. It's a whole team of people who know you and work together to give you the best care. It's led by your personal health care provider who gets to know you well and works with people like nurses and pharmacists to make sure everyone's on the same page when it comes to your care. There are also people on the team to help you with things like medication costs or insurance questions. Basically, your team is made up of whoever you need, so it changes as your health needs change. For example, if you need a specialist, your team can help you find someone who's right for you. And your personal provider will keep up on everything and help make sure the whole team is in the loop about your treatment. In fact, many medical homes also use things like electronic health records to help coordinate your care. That way, you don't have to keep going over the same information with each healthcare provider. Look, your time is valuable, and your team knows you've got a lot going on. So with Medical Home, it's easier to get care when you need it. If you've got a problem at night or on the weekend, they want you to call. And you may be able to get the help or information you need without even going into the office. Or if you need to come in, the schedule during the week is actually a lot more flexible. So you can often get a same-day appointment or even a longer appointment if you need it. But patient-centered care isn't just about getting help when you or someone in your family gets sick. It's about preventing problems so you stay healthy. They'll make sure you get things like a yearly checkup or any shots, and your care is tailored or custom-made based on your health and family history. So if you need any kind of test, they'll contact you to explain the results and schedule any follow-up care. Because once you have the whole picture, you and your provider can work together to make decisions about your health. It's a partnership, so speak up. After all, they want you to ask questions, and they want to hear about anything you'd like to change or improve. Do you need to get more sleep, lower your cholesterol, or lower your stress level? They'll help you set goals that make sense for you. Then it's up to you to make those changes and to let them know how it's going. And when it comes to things like asthma, diabetes, or high blood pressure, they know this can be overwhelming. So your team will make sure you get the tools you need. They'll also take time to explain everything, make sure you have the support and resources you need, and listen to your concerns. Because caring for the emotional side is just as important as the physical side. After all, you're not just a name on a chart, you're a whole person. And with the patient-centered medical home, your team provides health care that fits your life. So you feel taken care of and, well, at home.
All right, so that's just a really brief kind of overview of what the medical home model is at the national level. And I wanted to give you a sense of the timeline as well. This was put out in March of 2012, so it's still a relatively new concept that we're still in the process of developing. It's primarily out of primary care. So you can see that it's not directly transitions of care other than the handoff back to primary care. But the concepts really are important for what we want this model to be when we talk about coordination. Some of the key points that I want to pull out of the video is that the problem, according to this video, is that no one knows what the others are doing. We have that feeling in transitions of care all the time. Coordination, who knows what, when, who needs to know what when, what is the ideal versus what is practical, what is optimized, what is safety, what is efficient. All of these are things that we deal with in transitions of care in trying to coordinate all of these moving parts. The goal here was better, more personal care. That's easily a transferable idea. I think we all want better, more personal care. The concept that the medical home is not a place, it's a philosophy. This idea is really important in Colorado's history around the concept of patient and family-centered care. And we'll see that come up again in just a minute. And it's a team-based approach. Here it's led by a physician. There's been pushback on that idea. If you're calling it patient-centered, family-centered, why is it physician-led? Who's really the right person to lead? And does that shift over time? Could it be a patient during some points in time? Could it be a family member during some points in time? And is it a physician or some other care coordinator at other points in time? So I think that these models are really great to get us to think about things, but they're also much more fluid than it appears when we start talking about them on paper. The idea of whole person care, mental and physical care, is brought up in this model. And they also brought up that patients need help with their questions. They need help with support and resources. They want patients to call when they have questions. You don't need to go to the office to get help. All of these are issues that, even though they're talking about primary care, are issues that come up in transitions of care and are particularly important when we're trying to help people stay out of the hospital and not have to go back, as all of these governmental mandates are coming down. This is a really big deal. Prevention is being emphasized in the primary care setting. And then we need to think, is that really a realistic goal for a transition of care? Maybe it is in some circumstances. We want to prevent them from going back. But is that the immediate need at the moment? And where is the continuum going to be in these models? So the next thing that I want, let's see if I can get the slide to switch over here. It looks like, there we go. So in Colorado, I want to highlight the great work that's being done here. We really are at the forefront and on the cutting edge here in Colorado. And you all are a part of this movement of trying to develop what is patient and family-centered care here in our own neighborhoods. So this statement is what came out of CDPHE in 2007, that task force that I told you that I helped with. And I really wanted to give you a chance just to read it for a second and reflect upon what does that mean for your work. So as you can see, I kind of pulled out a couple of things that I thought were particularly important for the stuff that we're talking about today. Patients taking an active role in promoting good health, actively participating in their own care, partnering with patients and family members, collaborative decisions. These are all things that we talk about during transitions of care as well. And Colorado really was innovative in coming up with these ideas before it really became part of the literature. The 7 essential components of a patient and family-centered medical home here in Colorado, as defined by CDPHE, is that it is accessible, family-centered, continuous, comprehensive, coordinated, compassionate, and culturally effective. And if anyone is interested in seeing the actual definitions for each one of these bullet points, I'm happy to share that with you. But what I really wanted us to think about is how many of you knew, again, quick yes or no, how many of you knew that CDPHE had a medical home initiative? Just quickly put in your comments. Yep. So we've got a little bit of both. So that's great if you know. You have a voice. You can be involved. You can go to the open meetings as part of it. That's great for those of you that know about it. Those of you that want to know more, please get in touch with me afterwards. I'm more than happy to get you connected with them. Colorado really is a leader in developing these concepts. And how do we take this good work, even though it's really based on the pediatric realm, and put it to good use with your Medicare population? One of the gaps that I see in this is that we assume, when we say active role, we assume that someone has the ability. So what happens when the patient is not capable, as is the case in a lot of transitions of care? Again, assuming that someone has the possibility to be active, well then if they don't have the possibility to be active, who does? And who is that right person? And is that the patient's wishes? Those are the issues that add just extra layers on to this great work and these great frameworks and concepts that have already come out of the work in Colorado. And like I mentioned before, this is based on ambulatory pediatrics, but transitions is a different stage of care. The focus is not only on preventing illness as it is in pediatrics. It's just one component of a treatment plan, but it may not be the main goal, which I already mentioned a little bit earlier. So one of the youth, the people on the youth council for CDPHE made this comment, Emily. She's really, it's a really profound comment, I think. And she said, having a medical home is your guidance counselor for your health care. And I love this analogy. This is a powerful way to think about our role in the system. We are the guidance counselors. Can we shift our role from doing for patients to guiding them and doing with them so that they come to the decision that's right for them? This is a huge shift in how many of us have been trained. We have the education. We have the knowledge through understanding medical journal jargon. We have access to the right treatments and tools and equipment. We know what is best. Or do we? So I just want us to take a few minutes as you're brainstorming. I can already hear in my head your wheels turning. Just take a minute and jot down notes for yourself. What gets in the way of good transitions? And if you want to share any in the comment section, that's great. If you don't, keep it to yourself and jot it down for yourself. Poor communication, great. Thanks, Jan. Lack of transparency and knowledge of how Medicaid and Medicare work, absolutely. It's confusing. It's confusing for us, it's confusing for patients, it's confusing for families, silos. Yep, you got it. So a lot of that has to do with how we include patients in the process. Is poor communication between providers? Is it between the provider and the patient? It could be all of those. It could be with the next place that they're going. What are the systems that we have? Perfect. So looking at your notes and those ideas you just came up with, Who's at the center of the work in the system right now? In your community, who's really at the work? Is it trying to make it easier, more efficient, safer, better, more cost efficient for the system, for a provider, for a patient, for whoever is catching the patient, the next place? That's just food for thought as we keep going. Keep thinking about who's actually impacted by all of this. So where is the patient and family in these models? We have them listed, but where do we actually go from these big models and concepts to actual care where patients, family members, and the healthcare team are all engaged? So I know that you all already had a webinar series on the PAM, so I'm not going to spend time on it. I just wanted to, kind of brief your memory, refresh your memory without going into any detail. But I do want to point out that with the PAM, it is assumed that activation is not only beneficial, we assume that activation is beneficial, but that it's also desired by both parties. And so I want to go quickly to the patient activation definition that came out in Health Affairs in 2013. A patient's knowledge, skills, ability, and willingness to manage his or own health and health care. What are some barriers you have seen to patient or family member in their ability to be activated? If you type in some quick answers in the chat feature. What are some barriers you've seen to a patient or a family member in their ability to be activated? Afraid to speak up. Yep. Great. Providers don't ask open-ended questions. Fantastic. Trust and knowledge, both. And you added a piece on that's not in here, trust. And that sometimes has to do with power dynamics as well. We do things for them, right? We're not doing it with them or allowing them to do it for themselves. Finances, this is a real practical thing. Lack of knowledge, knowledge comes out again. Telling patients what to do versus asking what their goals are. And this goes into motivational interviewing techniques some of you may be familiar with. Their goals are different than the provider's goals. Exactly. I love these. This is perfect. So when I see this definition, I think it's a great start. But when I think about it a lot more deeply, I really step back and think about how each of these analyze that there's a choice. We assume that patients and family members have a choice in the decision-making process in being activated. And I really want us to push on that. Even though I think it's great for us to help patients be activated, there are barriers beyond knowledge, skills. It goes a little bit with ability and their willingness. So my goal for today is to get you to think about what can we do to encourage and support activation in a way that is culturally sensitive and really values their priorities, their goals that already came out in the answers, Angie's answer there, and the competing priorities that Peggy's talking about, absolutely. How do we even deal with that and allow someone to be activated? And what does activation even look like? But I'm going to step back and say, is activation even a good thing? We assume that it is. There's data showing that there's better outcomes, better quality of care, lower cost. Patients adhere to medications, which is important for transitions, particularly for transitions. Also, they're less likely to use the ER, and also they're less likely to be readmitted for post-discharge, which is what a lot of us have initiatives that we're working on right now. We have data showing that activated patients get us to these outcomes. And all of these models are not only beneficial but desired. That's the assumption. Let me step back for a second. Who is it desired for? Whose goal is it? Who benefits from activated patients? How do they benefit? Those are just some food for thought while we keep going through this discussion. So, of course, the big question, how can we build on these models for safe care transitions? So some frameworks that Own Your Own Health uses is really thinking about this simple distinction. But I think it's really important, particularly for those of us that work in the healthcare setting, to really say, what's the real goal here? The real goal here is health. wellness, well-being, whichever term we want to use, all of that is in the literature. But one way to accomplish health is through healthcare. Healthcare in and of itself isn't necessarily the goal. And one strategy is to provide safe transitions between settings, which is what we're really focused on. Our aim of health is to allow quality of life, not just quantity of life. And I'm sure you all have already read about this stuff, but I just want it to be on our forefront of our mind as we're really thinking about how do we engage then. If the goal is health, wellness, well-being, holistic, mind, body, spirit, all of those things that in the literature are deemed as the most important goal, is that really the ultimate goal? And also during transitions, we're forced to think about the distinction of quality of life and quantity of life. For example, palliative and hospice really push us to reconsider ideas about the intersection between not just life, but living, health, and healthcare. And transitions of care are really the opportune time, and we're kind of pushed into it, whether we want to be there or not, we're really pushed into thinking about those distinctions. One strategy we're working on at the system level is this idea of patient and family-centered care. And that's a set of buzzwords that we use a lot. We have a lot of names for it now, the health neighborhood, lots of different health community, a lot of different names that we have for it. And many of you have probably heard the same thing I heard from Carolyn Clancy a few years back. She said that we need to get the right treatment at the right place at the right time. And I've added to that, by the right person, because we also have models saying we need to get people up to the highest scope of practice. And then we have other models saying maybe we don't even need to have healthcare professionals. We could have promotors or other community navigators or family members or the patients themselves really engaging in this care. So all of that starts to come to an intersection of who's the right person too in this. And the most powerful framework that has stuck with me that I heard from Eileen Forlenzat say to PHE, nothing about me without me. Nothing about me without me. With, not for. And that already came up in the responses in the chat already. Let's pause to just really think about that distinction. Nothing about me without me. How do we do that in a transition of care where someone may be unconscious or may not have the physical capacity to do that? So I started really thinking and trying to draw out a model just for Own Your Own Health that I'm going to share with you to try to make sense of what I know and what I've learned. So there's a balance between the patient saying, I know myself the best, I know my body, and providers having specialized training. There's a balance between a patient or a family member being engaged and respecting the power and authority of the healthcare professionals and the system. There's a balance between the time constraints of the system and the time it might take for a patient or a family member to figure it out. What's the balance? There's not a simple answer to that. Can you all think of any other dichotomies of thinking that you have to learn the balance between that I didn't have up here? Anything to add to this model of how do you learn that balance? So I don't see any coming in. If you think of any, feel free to go ahead and put them in there. So the next thing that I really started thinking about is we tend to dichotomize patients of underactivated and overactivated. And reimbursed services versus volunteer time. Great, I love it. Perfect. Thanks for adding that in, Angie. So when I conceptualized of underactivated patients, I looked at the literature and I looked at what I was doing with patients and consumers myself, and I was feeling that people who are termed underactivated or perceived as underactivated really needed information and skill development, which is a lot of what Own Your Own Health does. And they needed to build their confidence, and we needed to include social support and not see it as an individual process. In addition, there needed to be community resources and coordination. And that's a lot of the work that you all are doing. And We also need to recognize that someone that's underactivated may need options that weren't put on the table because those options don't match their value system or their culture. And we make an assumption, again, I'm going to bring this out again, that people are making a choice not to engage. And I'm going to push back just a little bit that maybe it's not a choice. Maybe it's a structural issue, and that's something we can help deal with. I'm going to read the comment here real quickly. Providers may want their patient to change, but the patient may not be ready to change or change at the desired pace. Exactly, absolutely. So we have the readiness for change scales that are out there as well. And that goes, again, to the prior comment of priorities and whose goal is it? Is it the provider's goal or is it the patient's goal or is it the family's goal? Is it the community's goal? Is it the church's goal? It could be a lot of different things going on at the same time. Thanks for bringing that in. On the flip side, we tend to talk about overactivated or hyperactivated patients. And I've heard this term when I was still in the Department of Family Medicine at the med school of patients who, particularly around immunizations. And that may not be the case around transitions of care, but this is the case that I've heard this term most often used of they're overactivated because they're choosing not to immunize their kids or immunize themselves. But some of the traits that I've read about and had in my experience is that the patient or the family member has the information, but that information is not synthesized. They're the ones bringing you the large stack on meds, on I'm saying Medscape, but that's not right, but WebMD, right? Here, I printed this out from WebMD. On the internet, it says that's where you see that situation of patient coming. They have all the information, but they haven't synthesized the information to make it an efficient and effective utilization of that knowledge. They have the skill to engage with the provider, meaning they're not afraid to ask questions, but they may not do so in a respectful way. They may not manage the time with the provider or the system well. They may not utilize the provider's professional expertise and are more on the I know myself better end of things. The provider may not have the knowledge of the information that the patient or family member brought into them. And so it's really hard to have a discussion when you're looking for advice on something that the provider knows nothing about. They may not know that treatment option or that oil or that practice that your community has taught you about. Options suggest, again, same issue as with underactivated patients, but the options suggested may not match their values. So if you're trying to put things on the table as treatment options and that doesn't fit their value or culture, then it's not really an option. And they may not be honest with the provider about what they're actually doing. Any other characteristics that I'm missing that you think of when you think of an overactivated or a hyperactivated patient? All right. So where's that balance? How do we have activated and informed patients? And so this is where I want to add something into what I've seen in the literature. I don't think it's good enough just to have an activated patient. You need to have an activated and informed patient. Now sometimes you can't get there. Sometimes the situation's happening too quickly. You can't be fully informed. And there really is no way to be fully informed. But if we have an activated patient that doesn't have some level of being informed, then it creates that chaos that we just talked about. What we're wanting to see is efficient interactions and appointments with the healthcare system. We want to see them be organized where patients and family members ask the questions that they need to ask, but they're informed questions that actually make sense for that situation. Again, on the flip side, providers in the healthcare system are asking informed questions. If you already know information about a patient and they have to keep repeating that information over and over again, that gets frustrating for the patient and family member as well. So that's a two-way street there. Being aware of their symptoms and life changes. Sometimes patients aren't necessarily even aware of what their symptoms are unless they're asked. It wouldn't occur to them to say, oh, this happened or this is different in my life It just doesn't occur to them to even update a provider with that information. Not that they're lying or even withholding the information, it just doesn't occur to them. And that they understand their treatments and diagnoses well enough to be able to make informed decisions about where they want to go and what their goals are. We want partnerships with healthcare providers, and this already came up, trust. Trust is so important. Anything that I'm missing that you all think should be added to this model based on your experiences? I know it's hard to do using the chat rather than an in-person discussion. But we'll do our best.
Dr. Brown, this is Kristen.
Yep.
We have about 10 minutes left.
Perfect.
Okay.
Thanks. So one tool I wanted to share with you, you may or may not know of the Patient's Bill of Rights. And so I just want to go quickly through 4 transitions of care, the Patient's Bill of Rights. First, you have the right to be treated fairly and with respect during transitions. We need to learn how to get our agenda and our personal feelings out of the way to allow the patient and family member to be respected wholly. This aims at the patient-centered medical home concept of culturally responsive. You have the right to care transitions that fit your situation. Again, this gets at cultural responsiveness and health literacy, which already came out in the discussion. You have the right to know why a care transition is needed. And this gets to health literacy and shared decision making. You have the right to say what you want and need during care transitions, and this gets to cultural responsiveness. Even if this is not the path we think is best, we are the guidance counselors. Remember back to that youth member, Emily's quote, we are the guidance counselors. This is very difficult if we believe there's a better option, but that better definition is based on our perspective, not that of the patient or the family member. You have the right to take part in planning care transitions for yourself or your loved one. And this is illustrated in the concept of shared decision making. You have the right to know your costs related to care transitions. And when developing a tool for the Safe Transitions Task Force in Colorado Springs, one of the family members who participated really kept focusing on, if I had known I could have paid for it out of pocket, I would have done it. And the option was never given to them. The providers assumed that because insurance didn't cover it, it's not something that they wanted to do. You have the right to know the people and organizations involved in your care transitions. And I've seen this happen all over of who's the one to know the information, and trying to get that up front, who's allowed to know what, when, is really important. You have the right to privacy and your health care information during care transitions. We all know about HIPAA. And at the same time, who does the patient want to have in the information, in that care transition? The last thing I really want to highlight is, am I going to be a problem patient if I speak up? And if you've ever seen the Seinfeld episode where Elaine has her medical records say she's difficult and that follows with her, that's really important, this concept of, am I going to be a problem patient if I speak up? And if this is something that you want to talk about outside of this, I'm more than happy to share my experience. But patients really are afraid of being labeled as problem patients and difficult. They're afraid that they're going to get worse treatment, their loved one's going to get worse treatment. So really keep that in mind. Just food for thought. Where is that activated or just right place? So some tips really quickly is get involved. That's the main tip. Get involved and really think about how you can help your patients and their family members get activated, get engaged. So some resources, you have access to this PowerPoint after. You can go to these to help your patients decide what type of treatment is better for them. And really think about, what is the real desired outcome here? And who is the desired outcome for? In the system, we utilize our health outcome measurements as proxies for health and healthcare. And these measurements are critical in understanding where there are gaps, but they're not necessarily great at measuring actual desired outcomes. So when you're developing your initiatives, really think about that. Where do you want to engage patients? There are multiple levels to engage patients in this process. And just really quickly, what Own Your Own Health does is we really help patients and family members engage in the system in a way that they are confident. Again, if you want to learn more, feel free to get back in touch with me. And we have a lot of different programs that we offer. And feel free to sign up for our newsletter. This is an example of how we got patients engaged in the system. We went from what was on the left, developed by nursing staff, to what was on the right, which included patient and family voice in developing the tool. What's highlighted is where the changes were made based on patient and family voice. Join our movement, partner, volunteer, refer, become an advisory board member, and of course donate because we're a nonprofit. So I want to thank Civic and Telegen, and if you have any questions, we'll spend the last few minutes on that.
Great. Thank you so much, Dr. Brown. I appreciate you taking the time to talk us through the work that you're doing and the importance of patient and family engagement. And I'd like to invite everyone on the phone to take the next couple minutes and enter any questions you have into the chat box, and we will facilitate questions that way. I'm going to go ahead and take presenter or facilitator prerogative and ask the first question, if that's okay. You know, a lot of what you talked about focuses on the need to change the culture on the provider side of things. What do you think is the first step in changing that culture to really become more genuinely patient-centered?
I think the biggest but hardest thing to do is really recognize that we come to the table with our own values and our own ideas of what's best for the patient. And it's incredibly hard to engage with someone that doesn't share that value system. I think that's the biggest challenge. But that recognition in and of itself is what allows us to try as best we can to practice value-free healthcare where we're supportive of what their goals are, and helping them figure out what their goals are is probably the next biggest challenge because they're embedded in a culture as well.
Yes, that's true. Ann Lights just asked if they can get a copy of the resources on the last few slides. And these slides are all going to be posted on the Healthy Transitions website in the next couple of days along with the recording of the webinar. So those will be available for you probably by the end of the week. Does anybody have any other questions for Dr. Brown? Are there any last words or comments that you would like to give? Oh, here we go. Angie Holly asks, how do clinics balance needing to meet CPCI measures, meet the numbers, with patient goals that don't meet the numbers?
That is a critical question, and this is one that I brought up with Pay for Performance when I was still working at the med school around, we don't have a system in place right now to not ding providers and clinics for patients making an option outside of treatment guidelines. We don't have that. So one thing I recommend is making sure to document what the patient goals are. And sometimes we don't know until they've left because we assume they can make the decision with the information right at that point in time. But in reality, think about like when we go buy a car, we go look at all the data and then we go talk to friends and then we go check it out and test drive it. We don't get to do that in the healthcare system. We assume people can make their decision right off the bat. So my biggest thing is build it into your system that you have a mechanism to demonstrate this is actually what the patient wanted. And right now the funders and those that are actually capturing the data to measure you with also don't have a mechanism. So put your voice out at the table and say, hey, this is a problem. Make sure your voice is heard. I'm happy to come on as a consumer advocate and say, this by requiring these types of pay-for-performance measures that are not flexible to be patient and family-centered, you're harming the providers that are providing good care. And I've actually seen patients getting kicked out of practices because they wouldn't adhere to treatment plan, well, where do they go then? They're the most needy. We don't have a system built for it. I don't have a great answer for that other than document, and really put up front that your mission is to be patient and family centered, and that's your goal, and then have a way to separate out those that chose a different option, that chose a different treatment plan, versus those that just didn't adhere because they didn't adhere.
Great. Meredith Koob has a question. If providers or communities are interested in involving patients in their work, do you have patients that might be interested in advising or participating?
Yes. We have a patient and family advisory council right now, and we are building up that council. Hopefully in the future, if we find the need for it, that we could do patient advisors or patient, just like the project I had the slide up really quickly for, of doing a focus group for if you're putting out a new resource, that we can come and do a focus group on that. Now, it depends. Yes, we do have patient advisory council that can help with that, but we also recognize that your culture of where you are may not match who is on our list, so we may need to help find people in your area if that's what you wanted help with. But that would be a negotiation of your needs.
Great. Pat Perry asks, how do you work with or around the payment system to get not covered modalities?
I'm not quite sure exactly what the question is asking, but I'll take a stab at it. So the not covered modalities, my first step would be to argue that sometimes families are willing to pay for it even if they're not covered. And we just need to recognize just because it's not covered by insurance doesn't mean they wouldn't be willing to use it. And that is the first step. The second step is, I guess maybe lobbying is not the right word, but really going to the insurance companies and the payment system and asking them to cover those modalities. I know that the Colorado Health Op is having a listening tour right now for their members, and I was lucky enough to go and to the one that was in El Paso County and talk about what is it our community needs to be covered. I don't know how quickly that would happen, but that's one insurance company I know that does have a system intended to hear consumer voice.
Yeah.
Not sure if that was your question.
Well, I would just like to, I think you, well, Pat, can you let us know if that was your question? Along those same lines, I would just like to second going to your insurance company. We here at Civic have already been approached by insurance companies who would like some assistance trying to figure out how to cover palliative care because their covered entities have asked for that service to get covered because that's what their values are. So it does actually make a difference. I just wanted to second that. Peggy, if that's not what you were asking, Pat, can you please clarify and just let us know? Peggy Budai asks, do you know about and what do you think about the Stanford Chronic Disease Self-Management Program?
I know that I have come across it, but I am not pulling it up in my head specifically. But I'm happy, Peggy, if you get in touch with me by email to either have a phone go look it up and have a phone conversation with you, or we could do by email. I'm more than happy to do that. I know that I've read information on it, I just cannot draw it up on my head right now.
Okay. Are there any other questions for Dr. Brown before we close up for today? Okay, I'm not seeing anything. I just want to say thank you again for coming in and taking the time to talk with us. And thank you everybody on the line for joining us. I hope it's been a valuable use of your time and that you've gained some information that you can use to further your care transitions efforts. If you have any questions, please use the contact information that was provided through the webinar or contact us at hello@healthytransitionscolorado.org and we can get you any information you need regarding the webinar. The webinar has been recorded and it will be available on the Healthy Transitions website in the next few days. And have a great day, everyone.